Hi, welcome to Podiatry Practice Mastery. My name is Don Pelto, and I have Dr. Doug Richie here. Welcome, Doug.
Thank you, Don.
Thanks for joining. We're going to do a little chatting about maybe one of the newest types of AFOs that you've helped to develop, the AeroSpring. Is that the newest one, or is there one even after that that you've kind of worked on?
No, that's the newest system, so to speak, that we've come up with just in the last 3 years, actually.
3 years. Well, what I'll kind of share my backstory of how I kind of started to use it. I have as all of us as podiatrists, we have a lot of plantar fasciitis patients and Achilles tendonitis patients that they might not respond to cortisone injections, trying shockwave, all these other things. They might get better, but not totally resolved. And I need something to use. I kind of explain it to them as temporary. I'm hoping they're not going to use it, but to offload it better than a cam boot for maybe 6 months or 9 months. And then hopefully once the tissue's repaired, they can get out of it. That's kind of how I use it. And it's worked fabulously for the patients I've had. So tell me the backstory behind this type of a brace. How did you get interested? Did it start out like this? Did it start out as something else?
I think it started with something else. I was given an assignment by Podiatry Today to write a summary article of research on the use of heel lifts and the effect of heel elevation in the shoe. And as most of us have used heel lifts in the past, we primarily address the Achilles, trying to offload the Achilles. Some people use heel lifts to offload the plantar fascia. And so as I started looking at research done on the effects of heel lifts, it was astounding to me to realize that in many cases, heel lifts actually increase activity of the calf muscle and increase loading of the Achilles, particularly elevated heel shoes. And I also ran into research showing how a carbon fiber AFO could actually decrease load on the Achilles and decrease contractile activity of the calf musculature. And so the more I looked into it, I realized, I think we could use a carbon fiber AFO to decrease loading of the Achilles and address all of these pathologies that we've now learned are directly attributable to excessive tension of the Achilles and calf muscle.
And why not just, and this is something, because I sometimes send people out in Massachusetts, Blue Cross Blue Shield, they have a carve out at Hanger. So I have to send people over to Hanger for these. And all they give them is a carbon fiber AFO, basically the non-orthotic portion of your device. And they do really well with just that. So Did it start out with just the carbon fiber and then you added the orthotic later? What was the idea?
No, as we know, carbon fiber AFOs have been around almost 20 years. And hence there's been some good research on their treatment effects. But as I looked into the availability of them, I found some manufacturers, almost all manufacturers, said you have to put a shoe insert on top of the foot plate. Otherwise, it's too, quote, uncomfortable. And I realized this flat foot plate was losing the opportunity to incorporate what we learned from the Richie brace, and that is that a customized foot plate that balances the foot in a podiatric way could augment the treatment effects of the carbon fiber AFO. So we didn't even consider introducing a carbon AFO unless we could combine it with our magic, which is really the use of a foot orthotic with it. And hence we developed these 4 systems, which that was really the innovation. No other carbon fiber manufacturer or distributor had thought about marrying a foot orthotic with the carbon fiber AFO to really maximize the treatment effects.
And so correct me if I'm wrong, but as I'm looking into this, if you want to do just a carbon fiber, it's kind of an off-the-shelf system. And what makes it custom is the orthotic portion. So I'm sure when I send them out, they just order it small, medium, large, give it to them. But what makes it custom and the benefit of getting an orthotic is that's what makes it custom. Is that correct?
Yes. And like you said, we already know just the simple carbon fiber AFO has really significant positive effects. But it's amazing when you combine the support under the foot with the benefits of the carbon fiber. Now, when you're really trying to address all aspects of plantar fascia loading, now you've really done it comprehensively, not just with one sagittal plane component.
Now, this is a custom device, and in my experience here, most insurances cover it. what the kind of a conversation in my head is, hey, you're going to use this 6-9 months until it offloads your tissue repairs. Then you won't need the carbon fiber portion of it, but you'll still be able to use the orthotic portion. That's kind of in my nuance. That's how I'm explaining. Is that kind of how you explain it to your patients too?
Yes, and you bring up a good point from a practice management standpoint. The carbon fiber AFO is almost universally covered by all types of insurance. But the minute you put the L3000, custom foot orthotic component on there, now you've got many insurers who don't cover it or cover it in a really restricted way. So oftentimes the patient has to pay for the foot orthotic component. But therein is your responsibility to inform them this is a long-term investment. This foot orthotic will last you 3 to 5 years beyond the time you have to combine it with the carbon AFO.
Mm-hmm. Now, how about in my protocol, I kind of work them up like the traditional way with plantar fasciitis, Achilles tendonitis. I don't jump right into the brace. And I've almost stopped using, I used to use some velocity braces to kind of almost offload it. And I didn't get great results with a non-custom AFO to off. I was trying to do it to offload, but it didn't really work. Do you have any opinion on non-custom type devices to offload? I haven't found any that work great.
Well, the Velocity and even the Richie brace, these are polypropylene plastic AFO devices, whether custom or non-custom. The problem is they don't have the energy storage and energy return properties of a carbon fiber device. So up until carbon AFOs, we traditionally use solid plastic AFOs. I mean, that goes back 75, 80 years. But they're relatively dead materials. They don't store energy and return it. And that's really what the carbon fiber AFO does to the calf and the Achilles. It takes over for the calf. It stores energy and releases energy so the calf doesn't have to. So we never recommended the Richie brace, even the restricted hinge model, to offload the Achilles because we just didn't think it had the physical capability as any plastic brace, whether it's custom or non-custom.
Yeah. Let's talk about, as providers, we're explaining this to patients. So we can say to patients, let's say we're talking about plantar fasciitis, okay? An orthotic, I usually say, can offload the heel 30 to 40%. It's going to offload it by putting pressure to the arch, stabilizing the heel. Going then now to the AeroSpring, like carbon fiber brace, I usually say it pushes it to the front of the leg, about 60% offloading. Are those relatively okay numbers? I kind of feel like I need to explain why I'm doing that, not just an orthotic by itself.
Well, I think what we should explain to patients is the arch, if you go online and learn about plantar fasciitis, which many patients do before they even come see you, everything looks at the arch. My arch is falling. I need to support my arch, and it's going to take the strain off the plantar fascia. But and many of our colleagues know, the Achilles is a bigger deforming force on the plantar fascia than the arch is. And more recently, we've learned that the windlass mechanism of the great toe joint extension is equally, if not more, deforming on the plantar fascia than even the Achilles. So what we really tell patients is, we have a lot of good research that there's 3 primary deforming forces on the plantar fascia, and this system addresses all 3. It addresses the Achilles, the arch itself, and the extension of the great toe or the windlass mechanism during the push-off phase of gait.
That's great. That's awesome. And so what have your experience been in like the pros? Let's talk about the pros and the cons of the brace. I'll explain one of the cons that I had, because I was kind of quick. I'm a kind of a quick starter. I got the thing, I threw it on the patient, and they came back. They said they hated it because it was too far forward on their leg. And then I read the instructions, and you can grind it down to make it push back. And because the plate in the bottom, the foot plate, is not custom. It's just a general size. So you sometimes have to fit that in the shoe. What are some of the problems with the AeroSpring that you've had with doctors? That was my problem.
And just to clarify, when we first released the AeroSpring, we had a standard carbon fiber foot plate, and then new technology has arisen where the foot plate has a material around the rim that allows you to trim it with scissors.
Mm-hmm.
So you don't have to use a grinder anymore. You can just trim with scissors. But the shoe fit is a little bit of a challenge, but solvable very much. I would say the biggest, if there is a complaint, it's the strut coming out of the shoe on the medial aspect of the ankle. It can bump into your contralateral leg, you know, because it sticks out.
Mm-hmm.
And depending on the girth of the ankle, it can actually potentially rub on the malleolus. And fortunately, we have a big allowance for that. But for these very large edematous lower limbs, you can't prescribe the AeroSpring. You have to go to a full custom AeroSpring where you cast the patient. I'd say that's 5% of all patients. The final issue, but it's a very good issue, is with the AeroSpring, particularly on the right extremity, you have to loosen the upper strap and release it when you drive an automobile. You want to be able to enable the foot and ankle to plantar flex to safely drive a car. That's a good thing because before the AeroSpring, 9 out of 10 practitioners would put a patient in a walking boot for those severe end-stage plantar heel pain before considering surgery, right?
Mm-hmm. Mm-hmm.
I mean, that's the favorite thing. Okay, I'm going to boot you for a month and we're going to hope this gets better. And walking boots have so many downsides, not the least of which is you have to take it on and off to drive a car safely. And the AeroSpring, you just have to release the upper strap and now you have full flexion. And we have a really compelling video of that on our website, which you can actually show patients, which is a really good selling point in my mind.
Mm-hmm. Yeah, so you don't have to wear the boot all the time. It's an option to not wear the boot.
Right.
We've talked about plantar fasciitis, Achilles. I did try it as well for midfoot arthritis because up to this point, my only option was it's called the meso, which is a kind of an Arizona gauntlet around the midfoot. And this is also, it's kind of good for everything. So tell me about the midfoot arthritic patients that we have. How does it help them? What's the science behind it and things like that?
Yeah, so the midfoot arthritis has always been a challenge for me clinically. And, you know, when I was in school and training and going to conferences, I never found anybody to really explain what the pathogenesis is of midfoot arthritis other than trauma. But we all get these patients, usually women more than men, who are in the 5th and 6th decade. They start getting this global arthritis at the TMT joints. And the instinct is to support the arch of the foot. And we put them in orthotics. I was amazed how many of them, the orthotic actually made them worse, especially if you used a rigid orthotic, which in my mind would support that undersurface of the arthritic joint best. But no, they wouldn't tolerate those well. And then later, as we started getting these multi-segment foot models and studies done in gait labs, we realized here again, the Achilles tendon in the calf is the primary loader of the midfoot joints. It's during terminal stance, right as the heel comes off the ground, that the tremendous compressive forces occur across the midfoot joints. It's not from the arch collapsing. It's this dichotomous battle between the Achilles contracting and then the body falling forward and body weight resisting it. And so by neutralizing the Achilles force and smoothing it out and letting the brace lift the heel instead of the Achilles, suddenly the midfoot pain gets better very quickly.
Wow, that's a great explanation of how it works.
And we also found, I'm sure you find, that people with midfoot arthritis seem to do better in a rocker style shoe, a Hoka style shoe. So there seemed to be something about that third rocker when we lift the heel and go up on the toes that seems to have a retrograde compression across the midfoot. And you put them in a Hoka and a stiff sole shoe, they seem to feel better. So that's really what the carbon fiber foot plate is doing. It's giving the rocker type effect all the way out across the toes, just like it does for the plantar fascia.
Mm-hmm. Mm-hmm. And any other diagnoses? Those are the three that I'm thinking of. Is there anything else that, I guess, drop foot, you could use it for a drop foot, I guess. But...
Right. That was our fourth system, is we knew practitioners would say, well, you know, these carbon fiber AFOs were primarily designed and continue to be used for drop foot. Can't you use it for drop foot? Well, of course. Particularly So people look at our line, we have 2 or 3 very good braces for drop foot already. But when would I use the AeroSpring for drop foot? I would use it for drop foot when there's also posterior muscle, calf muscle weakness. We get these patients with drop foot who have had either peroneal nerve trauma, perhaps muscular dystrophy, perhaps multiple sclerosis, where it's not just the anterior musculature, it's calf and anterior. So they have a combination of a drop foot and they don't have any push off. And orthotists would commonly put those patients in what's called a ground reaction polypropylene AFO, which had some loading and rebound. But boy, when you go in the carbon fiber, you get a great rebound and push off with no energy expense. So I think having that in our line for those drop foot patients that also have posterior calf weakness, it's a great adjunct to our line.
That's great. That's great. One other thing I was thinking about in terms of the what was it? Gosh. Oh yeah. One thing that I found a little confusing, and just to answer before people get it, sometimes you come in there and you get the brace, and depending on what you do it for, there's these huge heel lifts. And I'm thinking, how am I going to fit that in someone's shoe? I got the carbon fiber, I got the orthotic, and I got this thing that this thick. And I'm like, they're not going to accept this. So tell me how that got, and have you got kickback on it and things like that?
Well, we've kind of modified our protocols, but as you know, we started out, believe it or not, I started this system and did my first test on patients with Achilles tendon rupture.
Okay, it was on rupture initially.
Rupture. And so universally, and I don't know where this started, but we would put patients, if we decided we weren't going to operate on them.
Huge, yeah.
It was always this 30 millimeter heel lift. And it was like, where did this come from? And that was really what I discovered in my research is you put a patient in a 30 millimeter heel lift, often it makes them fire their calf muscle more because they feel like they're going to fall forward. It stimulates a fall response. And secondly, it doesn't really offload the Achilles that much. They've done studies where they put strain gauges in the Achilles of live patients, and they find that you can very adequately offload the Achilles with 20 millimeters and even as little as 10 millimeters. So the most we offer is a 20 millimeter heel lift, and we only recommend it for the initial 6 weeks after an Achilles rupture.
Okay.
But to offload the Achilles for chronic tendinopathy, no, we would just use a 1 centimeter lift.
Okay, because I know it comes with one in there. I think that's the 20, right? That comes in with the device?
No, on our prescription form, we give you the option. We don't tell you it's a 20. We recommend a 10 at least.
Okay, a 10.
But the practitioner has to check the box. We're not going to tell you what to use. And by the way, a 20 millimeter heel lift, it's kind of funny. You would expect you or I to put that in a shoe and that your heel would come right out the back of the shoe. And it actually doesn't. It's kind of interesting. If anything, it does on the contralateral foot because you got to put a lift on the other shoe. But when you have the brace and the heel lift, the heel doesn't slip out because the brace is taking over the action of the calf and the Achilles.
Oh,
it's
okay.
kind of interesting.
Yeah, interesting.
Women are the easiest to use the AeroSpring on because we just tell them to wear a wedge sandal or something on the other foot. They do great. But when you start shoving 20 millimeter heel lifts in shoes, there's a lot of people who just don't like the feeling of it. I agree. But it's a very temporary situation. The heel lifts are used primarily in the acute early stage of brace therapy for offloading the Achilles. But our goal is to get you down to 5 millimeters or even 0 millimeters within 6 to 8 weeks, because the brace really takes over most of it. The lift part isn't that critical.
And how early? Because I'm starting to do them earlier and earlier in terms of my treatment. It's certainly you're not going to come in first treatment. Most of my for Achilles are getting like series of 3 to 4 shock waves. Foam rolling, eccentrics, maybe some PT in the interim. And then if it's not getting better, is that where you have people go right to the brace, or are you talking like a year of Achilles tendonitis and then they're just not getting better? How are people tending to use it? What do you recommend?
Yeah, for both plantar fascia and Achilles, the research shows if you wait too long and let that condition come into the more chronic, which is 6 months, I don't care what you do to intervene, you've really, you've dug yourself in a hole, and the patient. So certainly you don't put every plantar heel pain that presents to your office, but you and I both get patients who limp in, who may have A, been to 2 or 3 other doctors, B, never been to a doctor, but they are in so much pain and they've had this pain for more than 3 months. In the back of your mind, this is going to be a tough one.
Yeah.
And they can't even get the heel on the ground when they walk. And instinctively, practitioners would take those patients and put them in a walking boot, thinking maybe for 3-4 weeks, I'm going to calm it down and then do all my other magic. Well, now we're saying this is a great time to intervene with the AeroSpring right from the start, because you already know this is going to be a long haul for this patient.
Mm-hmm. That's great. And the I know it uses a 3D scanner. That it's pretty much like scanning for orthotics, right? So pretty easy to scan for. You don't have to do plaster anymore with this device.
Correct, but you can take a traditional plaster cast. You can take an STS fiberglass cast, or you can scan, and that's for the custom component, which is the orthotic.
Yeah, the other one is just based on some measurements my staff do. So
right. Yep.
Neat. Well, I think we covered it in pretty good detail here. Anything else you want to say about the AeroSpring? We're going to focus just on this, and if not, just let people know where they can learn more about the brace if you want to, Dr. Richie.
Yeah, so you can order this system through any of we have 15 distributors that are on our website. You basically, as you just alluded to, need to take a couple measurements, and you definitely have to take a cast or a scan of the foot. And you just fill out the prescription form, and hopefully if you take a scan, you just transmit the data electronically. We can get the finished foot orthotic and the brace back to you in less than 2 weeks, which is great. The reimbursement on it is great. I mean, it's just amazing, these simple AFOs. Somewhere along the line, somebody lobbied Congress or Medicare and figured out a way to get these L codes really highly reimbursed. But, you buy this brace for less than half of what you get reimbursed for. I mean, the carbon fiber component alone is reimbursed for $700 or $800, which is amazing.
Yeah.
It's the foot orthotic part that can be a little bit of a challenge, but we all deal with that. We all dispense foot orthotics in our practice. We all know how to verify insurance or how to charge cash, and how to justify that to the patient because of the long-term benefits.
Yeah. Well, good. Well, I appreciate your time. This was very beneficial, very insightful, and I'll send you a copy of the interview when we're done.
Okay, great. My pleasure.